Well, hello, everyone, and welcome to Science by the Slice. My name is Philip Stokes, Education Coordinator at the Pi Center. I'm also joined by Dr. Lisa Lundy, who is co-hosting this podcast with me. And so I want to take a minute to just introduce the topic of this episode and who we're joined by. So this episode is also hosted in conjunction with the Southeastern Coastal Center for Agricultural Health and Safety. And earlier this year, we had a State of the Science meeting, and the topic for that meeting was rural agricultural health and the health needs of the agricultural workforce. And so during that meeting, we had really good conversations with some of our researchers and educators that were a part of that meeting, and we have some of them here with us today. So we wanted to do a podcast to follow up on some of those topics and conversations, and that's what we're doing here today. So in addition to myself and Dr. Lundy, I'm joined by Dr. Lauri Baker, as well as Dr. John Diaz and Dr. David Bies, And so I want to give everyone just a minute to introduce themselves and just go around and say who you are, a little bit about your background and kind of your research areas, just real casual. Let us know who you are. And so everyone who's listening has your voice, knows who you are. And then also we are video recording this podcast as well, so you'll be able to watch it on our YouTube channel as well. So Dr. Lauri Baker, you want to start us out?
Sure, happy to start. I'm an associate professor in agricultural education and communication here at the University of Florida, and I have a 65% research appointment and 35% extension appointment. Much of those appointments and that work happens through the Pi Center, and so that's why I'm affiliated with this project. As far as research interests, even before I came to the University of Florida, I was looking at zoonotic disease and communication issues surrounding that, and the opportunity to come here, those issues have certainly increased, and there's been a lot of opportunity for digging in deep on that research and what it means for rural communities and rural health, particularly agricultural workers.
Great. Thank you so much. All right, Dr. Diaz, how about you want to go next?
All right, so I'm Dr. John Diaz. I'm an associate professor and extension specialist in the Department of Agricultural Education and Communication. I also serve as a president of a group called Café Latino, which is the Coalition of Florida Extension Educators for Latino Communities. Really, my work focuses on increasing the competency and capacity of universities, extensions, nonprofit groups to serve Latinos and Latina immigrant groups in the United States, but across the world. And so I've been, obviously, because of the demographics of farm workers in the United States, I've been working heavily in that space, helping to better understand how groups like Extension can help to better serve the agricultural workforce in our country.
Thank you. And Dr. David Bies.
Hey, y'all. I'm David Bies. I am served for 10 years as 10 years and 1 month, actually, as the state health specialist for MSU Extension, Mississippi State University Extension Service. I am currently in an associate vice provost for health sciences role and interim head of campus at MSU Meridian. So still have a line back to Extension, and will always to continue my work with Extension. My time with Extension's really been peppered with a lot of different issues. I often explain to people that what family practice is to medicine, I am a state health specialist to attention to public health. And that is that, like, a family practice doc may see a 3-year-old with an ear infection at 8 a.m. Their 8:30 appointment might be an 80-year-old with dementia, and their next one might be a 40-year-old with hypertension. Well, my public health practice has been just that diverse because we, as extension professionals, take what issues are present and walk in the door, if you will. Among those issues has been farm stress and issues of mental challenges that our agricultural producers face. So I've spent quite a bit of time working on and around that the last probably 6-7 years, and I'm delighted to be with you all to talk more about this broad topic.
Well, thank you, Dr. Bies. So those introductions were actually really great to introduce what we're going to be talking about today. So of course, last but not least, Dr. Lisa Lundy, if you can maybe introduce yourself as well, tell us your affiliation with the Southeastern Coastal Center for Ag Health and Safety, and then kick us off and we'll get the conversation going.
All right. Hi, I'm Lisa Lundy. I'm a professor in the Department of Agricultural Education and Communication, and I'm also part of the Outreach Corps for the Southeastern Coastal Center for Agricultural Health and Safety, and was a beneficiary of a conversation along these lines among this group earlier this year, and very excited to share that conversation and a little bit of that here with you today. So we're going to actually kick off with Dr. Diaz. And Dr. Diaz, if you would tell us a little bit from your perspective, of course, we know we just heard from Dr. Baez how varied it is, but describe the agricultural workforce to us. Who are our agricultural workers in terms of just demographics and makeup, and then what are some of their unique healthcare needs?
Yeah, so the makeup and demographics of the agricultural workforce has been changing for some time. If you look back at the 50s and 60s, farms were predominantly farmed by families. So there was a lot of family operators and family farm workers. But as time has passed, we're seeing a lot of those family farms going by the wayside, and most of the workforce is externally hired. Nowadays, we're seeing most of those external hires being either immigrants who are living in the state that they reside in, or are temporary workers through an H-2A visa program. Nowadays, even just the sheer number of farmers and farm workers is down. So back in the 50s, it was around 10 million, and we're just over 2 million now, with about half, if not more, being hired external workers. And so those higher external workers, the H-2A program, back in 2022, which is the last data I had, they were contracting about 372,000 farm workers. And that does not even take into consideration the large segment of undocumented workers that work in the agricultural industry. So when we couple that and thinking about healthcare, there's a lot of healthcare needs that are tied to the realities of those workers. And so because they're part of a really arduous and rigorous work type, they're exposed to a lot of different risks, whether it's pesticide exposure, heat exposure, of the plethora of other risks that come with farm working. In addition to that, because their life is somewhat turbulent, whether they're a temporary worker, an immigrant, or just a domestic worker working 7 days a week, as Dr. Baez said, there's a lot of issues related to mental health. And so it's really the scenarios and the needs within agricultural workers is very complicated, which makes serving them and understanding how to serve them complicated onto itself.
Yeah. Thank you so much. That gives us such a great overview. And I know you've painted such a picture of the workforce. And I know you've been involved specifically in some outreach health clinics for agricultural workers. In your experience, what are some of the things that prompt someone to come in, or maybe what are some of the things that present in those settings as far as healthcare issues?
Yeah, so one of the biggest healthcare issues that we see on a regular basis is issues of chronic disease. Because these farm workers are of low socioeconomic status, they cannot afford to eat fresh fruits and vegetables. And so they're really relegated to eating a lot of processed foods and eating a lot of processed foods within a very tight schedule. So if it's something they've prepared themselves, or going through a drive-through when they have 5 minutes to spare. So for example, with a lot of the farm workers that we're seeing, their A1C levels are at astronomical levels. So A1C levels of 10, 11, 12, 13, 14, and 15, where prediabetes and diabetes are in the 5, 6, and 7 range. And so just trying to wrap our heads around, what that looks like and why they're having these issues. And again, it comes back to kind of the realities of their life and their inabilities to access not only healthcare, but those fresh fruits and vegetables and healthy foods that they would need to prevent them from getting issues like diabetes.
Yeah.
Dr. Diaz, you talked about, you brought up access, right? And the realities of their life. And I think a lot of times when we discuss healthcare, we think about being informed of the appropriate choices to make. We try to get these things taught to us in school as we're growing up. But as you mentioned, these workers and this agricultural workforce, they're coming from all over the place. And so thinking about just access to information, or access to healthcare, or access to healthy food, knowing it is there are barriers that come in between that. So what are some of, Dr. Baker, I want to ask you, what are some of the factors that influence the choices that people make when going about their healthcare, and maybe relate it back to some of the research that you've done in that area?
Yeah, absolutely. One of the models that we like to use a lot at the Pi Center in this kind of work is called the health belief model. And essentially in that model, really, there's an element of how much you believe you are at risk or that you believe you're at danger. And so thinking about some of the things that Dr. Diaz says, if you have grown up in a family that has always worked outside, has always been in potentially transient migrant communities where you were working 7 days a week, you may believe that that's very normal, and you may believe that you aren't at risk because those are practices that are happening all the time around you. And so people's willingness to take action on preventative health care is much lower if they don't believe that they're at risk. And so that's one of the things that we've really tried to look at in the Pi Center. We did 5 different surveys throughout COVID. And during that time, one of the things that really kind of kept coming out in this data was that there was a real difference between rural and urban communities and their trust in science. And we found in many of our models that was predictive of whether they would be willing to seek care, whether they would be willing to get a vaccine, so a preventative type of issue. They were also very, very influenced by the people around them. And so as we kind of heard Dr. Diaz reference, many of these communities are Spanish speaking. They may have just different trusted information sources. They may not be listening to programming in English. And if that's the only way that we're delivering those messages, that could be a challenge. One of the other things that we've really seen, as I mentioned, kind of zoonotic disease being something that we've worked at a lot, is recently we've seen with climate change and other issues surrounding that, an increase in vector-borne diseases. And so just this past year, Hardee County in Florida had over 20 cases of dengue that were locally acquired. And so we just received a grant this week, actually, hot off the presses, from the CDC and the State Department of Health to really dig deep into that issue and see. Prior to that, a lot of the dengue cases that we'd been seeing in Florida were not locally acquired, meaning that while they were reported within the state of Florida, they actually, were bitten by a vector overseas, and then they came here and were diagnosed. So the locally acquired cases are a much bigger concern, right? And so as we're starting to have some of those conversations, we met with Hardee County Department of Health, and they said, as they're going and having conversations with farm workers, there's a lot of cultural differences there. And so they may be leaving doors open. They may be allowing livestock, chickens in particular, in and out of the house. There may be standing water, things that we all know could be preventative actions. So kind of tying back to that health belief model, we're going to go into those communities and have some conversations about their trusted information sources. Who are they listening to? What would make a difference in them taking some of those preventative actions, in this case, toward preventing dengue cases?
Yeah, Dr. Wise, I'm wondering if you could follow up on that a little bit. We've talked, Dr. Baker really got us off to such a good start thinking about the health belief model and the things that, whether it's our own perception of the risk or even our own perception that we have the self-efficacy to do something about it. But in terms of things that are outside of agricultural workers' control, things that are in their environment that are impacting their health, can you talk a little bit about those things and some of the work you've done in that area?
Yeah, and I love that this question got pitched to me. I don't know that y'all know this, and the listeners certainly most likely wouldn't. My doctoral work was in medical sociology, and so I tell people that you can distill that 4 years of education into this very simple statement, which is kind of like, thank you, Captain Obvious, but that people can only choose from the choices available to them. And I think as we think about these, yes, absolutely, we need to be understanding what motivates people to act, why are people engaged in the behaviors internally, what drives those the decisions they make. But we've also got to work, as Dr. Diaz just said, upstream. We like to use that phrase as well a lot in the public health space. It's upstream of the problem. What's the environment where people are, what are they living in and working in? There's the construct of the notion of the social determinants of health is not really new anymore, but it's all things considered, kind of in the grand scheme of public health history, it's a relatively new concept, and that's really just the notion that these are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of things that can affect people's health. So again, I'll say where they're born, where they live, where they learn, where they work, where they play, where they worship, and where they age. So very a wide range of things. We kind of group those into a fewer number of domains. Those are economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and then the social and community context. So, as we think about those, Dr. Diaz and well, I think all of us have referenced the kind of pressure, the family pressure that many of these farm workers may face to continue to generate an income for their family. It may be that they come from backgrounds that they don't have the education and didn't have the access to education, either previously or currently, to understand why these behaviors that are so important are important for them. And then once they are ill, able to get to a healthcare provider, that healthcare access and quality piece. And if they are, it may just be a one-off urgent care kind of situation, which better than nothing, but still may not be enough to help them fully recover and get back to the operation as quickly as possible. The neighborhood and built environment, we know that housing for a lot of farm workers is really compromised, and just that living standard can affect their ability. If we're talking about housing where spaces aren't fully sealed, there may be environmental risk that they face just due to their housing environment. And then their social and community context. Are they living in a community where the social norms are such that they would be compelled to, are these normalized behaviors? So the social determinants of health are absolutely a helpful way for us to think upstream of these behaviors that we want to promote, that we know are health promoting. They're health promoting behaviors, but they don't have the environment. Those choices are not available to them. We need to also be thinking and working in that space.
Yeah. And as I was listening to what you're saying and thinking about, you can only choose from the choices available to you. And then thinking about some of our agricultural workers, that those choices are not constant. They may be following, moving to different locations for, different growing seasons.
Right.
How does that further complicate? And this is really for any of you, your situation when those choices are always kind of in flux.
Well, I'll just jump in, initially just say, just learning a new environment. And even if you go to a similar environment, the same environment year after year, but you're only there for 2 months, 3 months, whatever the stint is, it's going to be challenging to really embed yourself and understand where to go to clinic, where to go for those, get that PPE that you might need that's not provided by your employer. Just learning the environment is difficult. And if your number one goal is to generate income for your present living situation and to send back home, then these other things are really secondary.
Absolutely. And I think what complicates that is just the financial landscape that's coupled with healthcare. And so, a lot of these rural areas, the only available healthcare options are either a hospital, which we see a lot of rural hospitals are closing, or federally qualified health clinics. Federally qualified health clinics are a great initial option for a lot of these farm workers, but if they were to see a primary care physician and needed some follow-up care from a specialist, that's where we see a lot of the healthcare options stop. And so, you couple the changing environment, you're migrating all over the place, and then the changes in insurance based on state and legal status, it just makes it, again, the decision-making process, a lack of familiarity and awareness, just makes it really complicated for them to know. And so at the end of the day, they know they need to work, they need to be there for their family, and that's an easy decision that they know how to manage. And so That's what ends up happening is they make decisions for their family before themselves.
Yeah. Well, I mean, we definitely have identified, and I'm sure there's many more that we haven't identified, some significant challenges in this. From you all's perspective, whether it be communication, extension, healthcare delivery, what are some solutions that you've seen that you think are really working or have a lot of potential? Dr. Baker, do you want to start us off from a communication standpoint?
Sure, I'd be happy to do that. I think it's definitely one of those places where communication and education align pretty closely, and it's hard to distinguish between those as a whole. But I also think one of the things we've talked a lot about the self-efficacy of ag workers in particular, but the other piece that we've also looked at is those surrounding them and those who may have more power or ability to affect the livelihood of agricultural workers. So, thinking of property owners and farm owners and working with them to also understand how they can provide better spaces, how they can treat areas large scale, how they can help those people find healthcare opportunities and educate them, provide things in multiple languages and that type of thing. We're also working as a part of the Southeastern Center for Vector-Borne Disease. There are 17 different states, and we're about to dig into North Carolina specifically, where we've seen an issue where the ticks in North Carolina are testing positive for a lot of diseases, but we're not seeing in rural healthcare the report of those diseases happening. And so we're going to go in and do some qualitative work to understand, is this a diagnosis issue? Are those rural communities prepared to make diagnoses? Are they prepared to have those conversations? And so perhaps it's an educational gap there. Again, we haven't gone in just yet. We'll go in this fall and hopefully learn more. But I think all of us have really talked about this holistic approach. It's not just one thing or another. And so I think the more that we can look at the people surrounding these issues, the situations surrounding these issues, and places where we can identify gaps in education and gaps in communication and empower those that can make a difference to do that, whether that's through policy or whether that's through individual action, working through churches, working through schools. In many cases, children are kind of the gateway toward the education and communication outputs in those areas.
So I'll go the other direction. I'll go the other direction from what I answered in my last question, which, the last question I really dove in on the notion of going upstream and working at that contextual kind of level. But I'll go really even beyond the individual level behavior, and that is really, how do we change the hearts of the people, and grab people's heart, then you can grab their minds. And so one of the things that you all on this call know, but that our listeners may not, is that I worked last several years on a film project, and I wish I could take credit for actually production of the film. I don't know how to turn a camera on, so I have to give credit to our to my colleagues at the MSU TV Center for the actual work of the film development itself. But we developed a piece called On the Farm, and we have a first season that tells the story of 4 farmers and their families and the stressors they face, and then we've got a second series now that's just out, that premiered on our public broadcasting affiliate here in July. And what we found is that film that really captures the stories, the individual level stories in a very raw and authentic kind of way, is we show that around the state and around the region, is having a tremendous impact on increasing or improving the understanding that those that have the ability to make decisions that would positively impact our farm workers, it's that their eyes are being opened in a significant way. And an interesting story about that is that when we started the project, before we had our first film even in the bag, we had a significant sense of buy-in from some of our farm organizations here in the State Farm Bureau, being among them, and that, yes, this is great. We'll work on getting this out work with y'all to get this out to our county association meetings. And once the film was complete, the first season of the film was complete, when we started going down that road and trying to get them to make good on their commitment, what we found is that those local farmers who would watch this, and those that were like, say, the president of their county board for Farm Bureau, would take a look at this and they'd say, that's really well done and it's impressive, but we live this every day. We don't want to watch film about it. So we pivoted, and our primary audience for that film has been healthcare workers, those physicians, nurses, and this has even been embedded in courses in school of nursing, school health professions, not at Mississippi State, but at other places. And the evaluation data that we're getting back indicates that folks have no idea of what our farmers face, be it the farm owners or the farm workers. They are absolutely clueless. And in Mississippi, agriculture is our number one industry. And yet we're preparing people for professions that would interact with farmers. And until now, we haven't really had an intentional way of reaching those who would have such a significant impact on that population. So as proud as we are of that work and that film, and I would offer it to anybody because it's available on thefarm.life, I would just say the broader lesson here is to find a way. Got to find a way to grab the hearts of those that have the ability to make a change and impact farmers and farm workers for the better. Because until we've gotten, sometimes numbers speak volumes and data can change policymakers, but in a lot of levels, we've really got to grab people's hearts first and understand just how difficult a situation is before they'll really put their money where their mouth is and make a difference.
Yeah. And I agree with what both Dr. Baker and Dr. Diaz have said. And I think in addition to that, we've got to have clear communication. You got to be aware of what's going on. And we also have to play to the hearts and minds of those that are influential in this paradigm. But I'll take it even kind of bringing it all full circles. Once we've been able to create this synergy, I think it's important for groups like Extension to really go and meet folks where they're at. And so that's what we're trying to do specifically in the state of Florida. So, for example, we're going out to the farms to provide health screening, vaccination, and education. We're going to the churches that they're going to on their one day off and providing health screening, vaccinations, connection to local clinics, and all those different things. And in addition to that, they also have to take in part of worker protection standard training to maintain, for example, their pesticide application certification. So we're going to trainings like that. So we're finding places where they're already going to be to help to provide the education and the services that they need amidst the craziness that is their life. So I think that if we're able to bring those three things together, I think it'll help to make some real change and hopefully transform the health access and quality of care paradigm that farm workers are dealing with currently.
So, Dr. Diaz, you brought up Cooperative Extension, and I think that's kind of where we were going to go next, because I did want to ask, and Dr. Diaz, I want to hear your perspective from the state of Mississippi as well. But maybe briefly, what is Cooperative Extension, and what is this role in healthcare? Because I feel like it's a relatively new shift that we've seen, that we're asking extension agents to address certain healthcare needs that, maybe in the past it was more scientific or technical or agricultural focused. So, Dr. Diaz, do you have any, or actually both, I'm going to open it up to both of you if you want to comment on that.
Yeah. So first, Cooperative Extension is really the connection of land-grant universities to the communities in the state that they serve. So in the state of Florida, we have Florida A&M University and the University of Florida, who have a connection to the 67 counties and tribal reservations that exist in the state of Florida. And their goal is to build relationships with communities and connect them with information and science that's happening at the universities that they represent. So what is the role in medicine and public health? So I think COVID was an amazing case study to show how extension can work not only in chronic health and preventative health paradigms, but can also work in infectious disease and helping to mobilize communities in a more rapid way. And so at the University of Florida, we started to see doctors get extension appointments to have the ability to go out not only into communities to provide services, but also to provide education. And so we're really trying to build out that model and take advantage of the amazing work and the amazing relationships and connections that our local extension agents have made to bring health professionals to these communities and provide these services and education opportunities that they didn't have in the past. And so we're having really, really great luck in capitalizing on these great extension agents that are doing work with these communities. They're doing work in the space of public health. And now we've developed a coalition of partners that are focused on agricultural health and safety, and specifically increasing access to quality services, which were not there before. So represents a new opportunity. I think we may not have it all humming and buzzing the way that we would want to, but we're learning along the way. And my vision is to have medical professionals more fully integrated into the extension model. So it's not just colleges of ag and life sciences. We also have colleges of medicine, colleges of business, colleges of engineering, helping to transform, what we're working within today. So,
yeah. And I would just go, a little bit further back in history, and just for folks that don't know Mississippi, it's certainly the same. Mississippi State, Alcorn State University, both have agents in got the extension service, and across both universities, we have agents in every county. In fact, we're the only statewide that still has an 8 to 5 presence every day of the week in every county state. State Department of Health doesn't. The Human Services, Child Protective Services, none of those have fully operational 8 to 5 days a week services in every county. But Extension has remained committed to our mission to be fully present all the time in every county of the state. Historically, I would just say that the land grant universities, building out from the early 1860s to 1914, there was this evolution from being strictly a teaching focused operation to a commitment to take that teaching to the people, take that education to the people, primarily and initially around agriculture, but also including what we used to call home economics, now family and consumer sciences. A lot of states are moving to the concept of family and consumer sciences, transitioning to family and community health. And I think that may be a better way of framing where we are now, is that we really are doing family and community health work. In most states, I would say that we are really never intending to move to a provision of clinical services. That's not really who we are, but we are connected. We are one of the strongest assets and strengths that Extension brings to the table is a connection. And initially that connection from the university around agriculture, home economics to the communities, but also now as our universities have become more and more sophisticated and offered more and more services, we're able to kind of serve as a hub and bring in expertise from, as Diaz said, medicine, engineering, and the list goes on to those communities as well through this vehicle, through this mechanism. And it's an extraordinarily powerful mechanism. We had healthcare reform back in the early part of the Obama era, President Obama era, that the notion of health extension was written into the bill. Our model is one that others envy and would love to be able to replicate. It's not been fully rolled out. This notion of health extension, separate from cooperative extension, has not been fully successful. And so I think the fact that the healthcare industry envies what we do and we continue to be successful is all the more evidence that we need to be working together and pushing a greater focus on health through extension and through this powerful infrastructure that we have.
Dr. Baker, did you want to add anything about your work in extension or some of the communication efforts, or really anything else?
Sure. I think I certainly agree with everything that Dr. Baez and Dr. Diaz said. And I think extension is uniquely positioned to deliver some of that communication. In a lot of our models, looking at vaccination of children and looking at vaccination for COVID in general, community-based social marketing was one of the things that really impacted people's attitude toward getting vaccinated, as well as their intention to get vaccinated.
Can you share what that is real quick?
Yes, absolutely. Okay, I was going to say, essentially, what extension is built on that model. People are already embedded within these communities. They're members of the community. They're going to school. They're going to church. Their children are interacting with people in these communities. So they already are kind of boots on the ground. They're trusted information sources, while they're also plugged into science. And trust in science is another thing that we've seen in our models that have been really impactful in people's decision making. And so Extension has that opportunity to be in those communities, to influence all the things we've talked about today, to influence the social norms around health issues, people's self-efficacy to make decisions around health issues, particularly in rural communities. The other aspect is when we ask about trusted information sources and compare rural communities to urban communities, trust in Extension is much higher in our rural communities. So as we're thinking about rural healthcare, in many cases, they may not have a local clinic, but if they have a local agent, that person can certainly be a liaison, someone to help them get the right answers, get the right information, and continue to have, reminders and information about how they can connect more broadly. So I can't really think of a better vehicle than Extension to deliver some of those communication messages around health.
Yeah, and I'd love to piggyback on that. Essentially, what Lauri just said is the reason why the medical community has come to Extension. They're looking for trusted partners to disseminate message to the communities that they don't have. The Extension is viewed as more of a trusted messenger than our medical professional counterparts. And so they see it as a great partnership to help to influence those decision-making paradigms on the ground and hopefully get folks to get vaccinated, start to engage more in preventative health. And so it's been great to have that partnership where, as David mentioned, we're not here to provision health services, but we are that trusted connection so that when they come to the communities, they're more likely to put an injection in their arm because they know, hey, this is, John who's in my community who I've gone to school with or I've interacted with before. And I trust that he has my best interest in heart. So again, it's been a great connection and great vehicle to get some of the medical science implemented on the ground.
I would layer in that we've not talked about really research at all. And we talked a lot about evaluation or sort of needs describe generally work that Extension is careful to stay out of the formal research world. We're very much about practice and applied effort. And at the same time, we are a great partner for researchers. We're not here to be their research assistants or to simply be their data gatherers or their solely their access to participate for their studies. But when there are often synergies where folks with research grants can work with us, and we can we can plus up things for communities through research grants, and then the researchers also get the access they need for data collection. And it's a really, really remarkable partnership on that side as well, and lots of science has been developed to inform scientific implications from partnerships that Extension brings to the table. I am very careful to reemphasize what I said, that we're not sitting around twiddling our thumbs waiting for researchers to come, get us to give out their instruments or convene a focus group for them. But where there are synergies, we are ready and willing partners.
Dr. Lundy, do you have any other questions or thoughts to kind of wrap up today's conversation?
No, I just thank you, all three of you. I think that the three of you represent a lot of, like we've discussed, solutions and potential for collaboration. And so I really enjoyed hearing from all three of you today, and very thankful that you took the time to participate.
Yes, I agree with that. And to kind of echo what you said, Dr. Lundy, yeah, of course, we started out talking about the challenges and some of those barriers, but it really is encouraging to hear all of the work that is being done and some of the positive changes that have happened over time. Not always easily done so, right? But it's great to hear about the work you're all doing in those areas as well. So I just want to thank you all for joining today.
Sure. Thanks for having us.
Yep, thanks for having us.
Great. Well, once again, this is being video recorded. If you want to check us out on the Southeastern Coastal Center for Agricultural Health and Safety's YouTube channel. You can see it there. We'll also stream it wherever you get your podcasts. And until next time, be on the lookout for other episodes from Science by the Slice. Thanks so much for listening.